Good afternoon. If you don't find it difficult, subscribe to the channel, please. This will motivate me to work on some further useful videos, which I was not planning to make. Thank you for your subscription. Today I would like to introduce you the next pharmacology lecture, Drugs Acting on the Endocrine System, Hormones and Related Drugs, Part 1. But before the lecture, I would like to ask you to join the donations to the Ukrainian army to fight against the aggressor. The whole world is witnessing what is happening in Ukraine, and any donation will help the Ukrainian military forces in this difficult time. You can donate any amount to the Come Back Alive Foundation using the links on the slide and in the video description, or you can make a donation using PayPal service to this YouTube channel, and I will send all your donations to help the Ukrainian army. Links to donations are in the description of this video. Thank you. Glory to Ukraine. Lecture plan. General considerations: pituitary hormones, thyroid hormones and thyroid inhibitors, insulin, oral hypoglycemic drugs, and glucagon. Let's start from general considerations. Hormone, from Greek to stir up, is a substance of intense biological activity that is produced by specific cells in the body and is transported through circulation to act on target cells. Hormones regulate body functions to bring about a programmed pattern of life events and maintain homeostasis in the face of markedly variable external-internal environment. On the right side you can see different body functions and major regulator hormone or hormones. For example, availability of fuel, insulin, glucagon, growth hormone, metabolic rate, triiodtyronine, thyroxine, somatic growth, growth hormone, insulin-like growth factors, sex and reproduction, gonadotropins, androgens, estrogens, progestins, circulating volume, aldosterone, antidiuretic hormone, adaptation to stress, glucocorticoids, adrenaline, and calcium balance, parad hormone, calcitonin, vitamin D. Additionally, hypothalamus, as a part of the central nervous system and not a gland, produces many releasing and inhibitory hormones which control the secretion of anterior pituitary hormones. On the right side you can see some important releasing and inhibitory hormones of the hypothalamus which control the secretion of anterior pituitary hormones. For example, thyrotropin releasing hormone, corticotropin releasing hormone, gonadotropin releasing hormone, gonadorelin, prolactin release inhibitory hormone, growth hormone releasing hormone, and somatostatin, growth hormone release inhibitory hormone. Classification of hormones. Hormones are secreted by the endocrine or ductless glands. These are: first, pituitary, anterior, growth hormone, prolactin, adrenocorticotropic hormone, thyroid-stimulating hormone, and gonadotropins, follicle-stimulating hormone and luteinizing hormone. And posterior, oxytocin and antidiuretic hormone. Second, thyroid, thyroxine, triiodtyronine, and calcitonin. Third, parathyroid, parad hormone. Fourth, pancreas, islets of Langerhans, insulin, glucagon. Fifth, adrenals, in cortex, glucocorticoids, hydrocortisone, mineralocorticoids, aldosterone, and sex steroids, dihydroepiandrosterone. And in medulla, adrenaline, noradrenaline. And sixth, gonads, androgens, testosterone, estrogens, estradiol, and progestins, progesterone. The natural hormones, and in many cases their synthetic analogues, which may be more suitable therapeutically, are used as drugs for substitution therapy as well as for pharmacotherapy. In addition, hormone antagonists and synthesis-release inhibitors are of therapeutic importance. Sites and mechanisms of hormone action. The hormones act on their specific receptors located on or within their target cells. Receptor activation by the hormones is translated into response in a variety of ways. First, at cell membrane receptor, through alteration of intracellular CMP concentration, alteration of protein kinase A, regulation of cell function, calcium acting as the third messenger in some situations. Through inositol 1,4,5-triphosphate deacylglycerol generation, release of intracellular calcium and protein kinase C activation, direct transmembrane activation of tyrosine protein kinase, phosphorylation cascade, regulation of various enzymes. Under A, you can see examples: adrenaline, glucagon, thyroid stimulating hormone, follicle stimulating hormone, luteinizing hormone, paradhormone, some hypothalamic releasing hormones, and vasopressin V2. Under B, you can see vasopressin V1 and oxytocin. Under C, you can see in examples insulin, growth hormone, and prolactin. The second is at cytoplasmic receptors. Penetrating cell membrane, hormone combines with a cytoplasmic receptor, exposes its DNA binding domain, migrates to the nucleus and binds to specific genes, DNA-mediated mRNA synthesis, and synthesis of functional proteins. And here you can see examples of steroid hormones, glucocorticoids, mineralocorticoids, androgens, estrogens, progestins, and calcitriol. And third, at the nuclear receptor. The hormone penetrates the nucleus, combines with its receptor, alters DNA-RNA-mediated protein synthesis. The examples are thyroid hormones, thyroxine, and triiodthyronine. And the next part of our lecture is pituitary hormones. First, anterior, growth hormone, prolactin, adrenocorticotropic hormone, thyroid stimulating hormone, gonadotropins, follicle stimulating hormone, and luteinizing hormone, and posterior, oxytocin and antidiuretic hormone, vasopressin. Anterior pituitary, adenohypophysis, the master endocrine gland, elaborates a number of important regulatory hormones. All of these are peptide in nature and act at extracellular receptors located on their target cells. This secretion is controlled by the hypothalamus through releasing and release inhibitory hormones that are transported via the hypothalamo-hypophyseal portal system and are subjected to feedback inhibition by the hormones of their target glands. Each anterior pituitary hormone is produced by a separate group of cells, which according to their staining characteristic are either acidophilic or basophilic. The acidophils are either somatotropes, growth hormone, or lactotropes, prolactin. The basophils are gonadotropes, follicle stimulating hormone and luteinizing hormone, thyrotropes, thyroid stimulating hormone, and corticotrope lipotropes, adrenocorticotropic hormone. Corticotrope lipotropes, in addition to adrenocorticotropic hormone, also produce two melanocyte-stimulating hormones and two lipotropins, but these are not important in men. The first is growth hormone. Growth hormone promotes the growth of bones and all other organs by inducing hyperplasia, a proportional increase in the size and mass of all parts, but in the absence of gonadotropins, sexual maturation doesn't take place. The growth of the brain and eyes is independent of growth hormone. The growth hormone promoting is indirectly through the elaboration of peptides called somatomedins or insulin-like growth factors, IGF-1 and IGF-2, which are extracellular mediators of growth hormone response. The liver is the major source of circulating IGF-1, while IGF-1 produced by other target cells acts locally in a paracrine manner. Regulation of growth hormone secretion. The hypothalamus produces growth hormone releasing hormone as well as release inhibitory somatostatin hormones. Both are peptides. Somatostatin is also produced by delta cells of islets of Langerhans in the pancreas and by a few other tissues. And on the right side you can see a schematic depiction of action of growth hormone and regulation of its secretion. Preparations and use. The primary indication for growth hormone is pituitary dwarfism, 0.03 to 0.06 milligrams each kilogram daily in the evening or on alternate days, up to the age of 20 or more. Human growth hormone produced by recombination DNA technique, somatotropin, is available for clinical use. Drug names: norditropin, 5, 10, 15 milligrams injection, and humatrope, 6 and 12 milligrams cartridges, and 1.33 and 5.33 milligrams vials. Adverse effects: somatotropin has low immunogenicity, allergic reactions, or resistance to treatment are not a problem. It can cause pain at injection site, lipodystrophy, glucose intolerance, hypothyroidism due to unmasking of thyroid stimulating hormone deficiency, salt and water retention, hand stiffness, myalgia, and headache are the possible adverse effects. Rise in intracranial tension occurs in few cases. Growth hormone inhibitors. Somatostatin inhibit the secretion of growth hormone, prolactin, and thyroid-stimulating hormone by pituitary, insulin and glucagon by pancreas, and of almost all gastrointestinal secretions, including that of gastrin and hydrochloric acid. Use is limited due to short time of half-elimination, 2-3 minutes. The next is octreotide. Synthetic octapeptide, 40 times more potent than somatostatin, longer acting, time of half-elimination is around 90 minutes. It is preferred over somatostatin for acromegaly and secretory diarrheas associated with carcinoid, AIDS, cancer chemotherapy, or diabetes. Dose from 50 to 100 micrograms subcutaneously twice daily, increased up to 200 micrograms twice a day. The next is lanreotide, long-acting analog of somatostatin, very similar in actions and specificity to octreotide, indicated for pharmacotherapy of acromegaly. And pegvisomant, bind receptor but do not trigger signal transduction, is approved for treatment of acromegaly due to small pituitary adenomas. The next is prolactin, physiological function. Prolactin is the primary stimulus that, in conjunction with estrogens, progesterone, and several other hormones, causes growth and development of breast during pregnancy. It promotes proliferation of ductal as well as acinar cells in the breast and induces synthesis of milk proteins and lactose. Prolactin suppresses the hypothalamo-pituitary gonadal axis by inhibiting gonadotropin-releasing hormone release. Continued high level of prolactin during breastfeeding is responsible for lactational amenorrhea, inhibition of ovulation, and infertility for several months postpartum. Prolactin may affect immune response through action on T lymphocytes. Regulation of secretion. Prolactin is under predominant inhibitory control of hypothalamus through prolactin release inhibiting hormone, which is dopamine, that acts on pituitary lactotrope D2 receptor. Dopaminergic agonists, dopamine, bromocriptine, cabergoline, decrease plasma prolactin levels, while dopaminergic antagonists, chlorpromazine, haloperidol, metoclopramide, and dopamine depleter reserpine cause hyperprolactinemia. Physiopathological involvement. Hyperprolactinemia is responsible for the galactorrhea amenorrhea infertility syndrome in women. In males, it causes loss of libido and depressed fertility. The causes of hyperprolactinemia are disorders of the hypothalamus removing the inhibitory control over pituitary, antidopaminergic and dopamine depleting drugs, frequent cause now, prolactin secreting tumors, and hypothyroidism with high thyroid releasing hormone levels, also increases prolactin secretion. Uses. There are no clinical indications for use of prolactin. Prolactin inhibitors. Bromocriptine, synthetic ergot derivative 2-bromo-alpha-ergocryptine, is a potent dopamine agonist, most of its actions based on this property. It has greater action on D2 receptors, while at certain dopamine sites in the brain it acts as a partial agonist or antagonist of D1 receptor. And the next one, cabergoline. It is a new D2 agonist, more potent, more D2 selective, and longer acting. Time of half-elimination is more than 60 hours, than bromocriptine. Needs to be given only twice weekly. The next are gonadotropins. The anterior pituitary secretes two gonadotropins. First is follicle-stimulating hormone, and second is luteinizing hormone. Follicle-stimulating hormone in the female induces follicular growth, development of ovum, and secretion of estrogens. In the male, it supports spermatogenesis and has a trophic influence on seminiferous tubules. Luteinizing hormone induces preovulatory swelling of the ripe Graafian follicle and triggers ovulation followed by luteinization of the ruptured follicle and sustains corpus luteum till the next menstrual cycle. It is also probably responsible for atresia of the remaining follicles. Progesterone secretion occurs only under the influence of luteinizing hormone. In the male, luteinizing hormone stimulates testosterone secretion by the interstitial cells and is designated interstitial cell stimulating hormone, ICSH. Both are glycoproteins containing 23 to 28% sugar and consist of two peptide chains. The alpha chain is common as in follicle-stimulating hormone as well as in luteinizing hormone, but beta chains are different in these hormones. Physiological functions. Follicle-stimulating hormone and luteinizing hormone act in concert to promote gametogenesis and secretion of gonadal hormones. Pathological involvement. Disturbances of gonadotropin secretion from the pituitary may be responsible for delayed puberty or precocious puberty both in girls and boys. Inadequate gonadotropin secretion results in amenorrhea and sterility in women, oligozoospermia, impotence, and infertility in men. Excess production of gonadotropins in adult women causes polycystic ovaries. Preparations. All administered through intramuscular route, neurosubcutaneous, time of half elimination from 2 to 6 hours. Manotropins, follicle-stimulating hormone plus luteinizing hormone, is a preparation obtained from urine of menopausal women. Urofolitropin or manotropin, it is a pure follicle-stimulating hormone. Human chorionic gonadotropin, HCG, is derived from urine of pregnant women. And recombinant human follicle-stimulating hormone, RFSH, folitropin alpha and folitropin beta, and recombinant human luteinizing hormone, RLH, lutropin, as well as recombinant human chorionic gonadotropin, RHCG, choriogonadotropin alpha, have become available. These are more purified and have virtually replaced the urine-derived preparations in the developed countries. They are more expensive. The next is gonadotropin-releasing hormone or gonadorelin. Synthetic, used 100 micrograms IV, induces the prompt release of luteinizing and follicle-stimulating hormone, time of half elimination from 2 to 6 hours, followed by elevation of gonadal steroid levels. And gonadotropin-releasing hormone agonists. Nafarelin, 150 times more potent than gonadotropin-releasing hormone, time of half elimination from 2 to 3 hours. Goserelin, long-acting depot injection for 1-3 weeks. Triptorelin, long-acting, and leuprolide, long-acting. Uses of gonadotropins: amenorrhea and infertility, hypogonadotrophic hypogonadism in males, cryptorchidism, to aid in vitro fertilization. Gonadotropin-releasing hormone antagonists. Some more extensively substituted gonadotropin-releasing hormone analogs act as gonadotropin-releasing hormone receptor antagonists. They inhibit gonadotropin secretion without causing initial stimulation. The early gonadotropin-releasing hormone antagonists had the limitation of producing reactions due to histamine release. Later agents like ganirelix and cetrorelix have low histamine-releasing potential and are being clinically used as subcutaneous injections in specialized centers for inhibiting luteinizing hormone surges during controlled ovarian stimulation in women undergoing in vitro fertilization. Their advantages over long-acting gonadotropin-releasing hormone agonists include: they produce quick gonadotropin suppression by competitive antagonism, need to be started only from 6th day of ovarian hyperstimulation, they carry a lower risk of ovarian hyperstimulation syndrome, they achieve more complete suppression of endogenous gonadotropin secretion. However, pregnancy rates are similar or may even be lower. The next one is thyroid-stimulating hormone. Thyroid-stimulating hormones stimulate the thyroid to synthesize and secrete thyroxine, T4, and triiodthyronine, T3. Actions are: induces hyperplasia and hypertrophy of thyroid follicles and increases blood supply to the gland, promotes trapping of iodide into thyroid by increasing sodium iodide symporter, promotes organification of trapped iodine and its incorporation into T3 and T4 by increasing peroxidase activity, and enhances endocytotic uptake of thyroid colloid by the follicular cell and proteolysis of thyroglobulin to release more of T3 and T4. This action starts within minutes of thyroid-stimulating hormone administration. Regulation of secretion. Synthesis and release of thyroid-stimulating hormone by the pituitary is controlled by the hypothalamus primarily through thyrotropin-releasing hormone, while somatostatin inhibits thyroid-stimulating hormone secretion. Dopamine also reduces thyroid-stimulating hormone production induced by thyrotropin-releasing hormone. The negative feedback for inhibiting thyroid-stimulating hormone secretion is provided by the thyroid hormones, which act primarily at the level of the pituitary, but also in the hypothalamus. Use. Thyrotropin has no therapeutic use. Thyroxine is the drug of choice even when hypothyroidism is due to thyroid-stimulating hormone deficiency. The diagnostic application is to differentiate myxoedema due to pituitary dysfunction from primary thyroid disease. And the next one is adrenocorticotropic hormone, ACTH corticotropin. Physiological function. Promotes steroidogenesis in the adrenal cortex by stimulating CMP formation in cortical cells through specific cell G protein-coupled receptor, rapidly increases the availability of cholesterol for conversion to pregnenolone, which is the rare limiting step in the production of gluco, mineralo, and weakly androgenic steroids. Injected IV, 25 units, causes an increase in plasma cortisol if the adrenals are functional. Regulation of secretion. Hypothalamus regulates adrenocorticotropic hormone release from pituitary through corticotropin-releasing hormone, CRH. The corticotropin-releasing hormone receptor on corticotropes is also a G protein-coupled receptor, which increases adrenocorticotropic hormone synthesis as well as release by raising cytosolic CMP. Secretion of adrenocorticotropic hormone has a circadian rhythm. Peak plasma level occur in the early morning, decrease during day, and are lowest at midnight. Corticosteroids exert inhibitory feedback influence on adrenocorticotropic hormone production by acting directly on the pituitary as well as indirectly through the hypothalamus. Use. Adrenocorticotropic hormone is used primarily for the diagnosis of disorders of pituitary adrenal axis. Injected IV 25 units causes increase in plasma cortisol if the adrenals are functional. Direct assay of plasma adrenocorticotropic hormone level is now preferred. For therapeutic purposes, adrenocorticotropic hormone doesn't offer any advantage over corticosteroids and is more inconvenient, expensive, as well as less predictable. And the next part of our lecture is thyroid hormones and thyroid inhibitors. Thyroid hormones. The thyroid gland secretes three hormones: thyroxine, triiodthyronine, and calcitonin. Calcitonin produced by interfollicular C cells and is chemically and biologically entirely different, and it is considered along with parathormone, with which it regulates calcium metabolism. The term thyroid hormones is considered only for the first two, thyroxine and triiodthyronine. Chemistry and synthesis. Both T4 and T3 are iodine-containing derivatives of thyronine, which is a condensation product of two molecules of the amino acid tyrosine. The thyroid hormones are synthesized and stored in the thyroid follicles as part of the thyroglobulin molecule, which is a glycoprotein synthesized by thyroid cells. The first is iodide uptake. The total body content of iodide obtained from food and water is 30 to 50 milligrams, out of which about 1/5 is present in the thyroid. Concentration of iodide in blood is low, but thyroid cells have an active transport process, sodium iodide symporter, to concentrate this anion. Second is oxidation and iodination. Iodide trapped by follicular cells is carried across the apical membrane by another transporter termed pendrin and oxidized by the membrane-bound thyroid peroxidase enzyme to iodinium ions or hypoiodous acid or enzyme-linked hypoiodate with the help of hydrogen peroxide. These forms of iodine combine avidly with tyrosyl residues of thyroglobulin, apparently without any enzymatic intervention, to form monoiodotyrosine and diiodotyrosine, while these residues are still attached to the thyroglobulin chains. Monoiodotyrosine is MIT and diiodotyrosine is DIT. Third is coupling. Pairs of iodinated tyrosine residues couple together to form T3 and T4. Normally, much more T4 than T3 is formed, but during iodine deficiency, relatively more MIT is available and a greater proportion of T3 is formed. Thus, more active hormone is generated with lesser amount of iodines. Fourth, storage and release. Thyroglobulin containing iodinated tyrosyl and tyronyl residues is transported to the interior of the follicles and remains stored as thyroid colloid till it is taken back into the cells by endocytosis and broken down by lysosomal proteases. The T4 and T3 so released is secreted into circulation, while MIT and DIT residues are deiodinated and the iodide released is reutilized. Fifth, peripheral conversion of T4 to T3. Peripheral tissues, especially liver and kidney, convert T4 to T3. About one-third of T4, secreted by thyroid, undergoes this change, and most of the T3 in plasma is derived from liver. Target tissues take up T3 from circulation for their metabolic need, except brain and pituitary, which take up T4 and convert it to T3 within their own cells. The T4 to T3 conversion is carried out by the enzyme iodotyrosine deiodinase, which exists in three forms: D1, D2, D3. The antithyroid drug propylthiouracil, but not carbimazole, inhibits type 1 deiodinase, and the antiarrhythmic amiodarone inhibits both D1 and D2 forms. Propranolol, high dose, and glucocorticoids also inhibit peripheral conversion of T4 to T3, except in brain and in pituitary. And in here you can see a schematic depiction of synthesis, storage, and secretion of thyroid hormone. Thyroid stimulating hormone activates steps 1, 2, 3, 4, and 5, which you can see in here, 1, 2, 3, 4, and 5. Ionic inhibitors block step 1 in here. Excess iodide interferes with steps 1, 2, 3, and 5 with primary action on steps 3 and 5. So step 3 and 5 is the primary action. Propylthiouracil inhibits steps 2 and 6, step 2 in here and step 6 in here. Carbimazole inhibits step 2 only, in here. The next is regulation of thyroid function. The secretion of hormones from the thyroid is controlled by the anterior pituitary by the elaboration of thyrotropin, while TSH secretion itself is regulated by TRH produced in hypothalamus. Somatostatin elaborated by hypothalamus inhibits not only GH and prolactin, but also TSH secretion from pituitary. The relation between thyroid, anterior pituitary, and hypothalamus is depicted in the figure on the slide. The negative feedback by the thyroid hormones is exercised directly on the pituitary as well as through the hypothalamus. The action of TRH on the pituitary and that of TSH on thyroid cells is mediated by enhanced CAMP synthesis. Both T3 and T4 penetrate cells by active transport and produce majority of their actions by combining with a nuclear thyroid hormone receptor, which belongs to the steroid and retinoid superfamily of intracellular receptors. In contrast to the steroid receptor, the thyroid hormone receptor resides in the nucleus, even in the unliganded inactive state. It is bound to the thyroid hormone response element, TRE, in the enhancer region of the target genes along with corepressors, figure on the slide. These keep gene transcription suppressed. When T3 binds to the ligand binding domain of thyroid hormone receptor, it heterodimerizes with retinoid receptor and undergoes a conformation change, releasing the corepressor and binding the coactivator. This induces gene transcription, production of specific mRNA, and a specific pattern of protein synthesis, various metabolic and anatomic effects. The expression of certain genes is repressed by T3. In their case, The unliganted thyroid hormone receptor allows gene transcription, while binding of T3 to thyroid hormone receptor halts the process. Many of the effects, for example tachycardia, arrhythmias, raised blood pressure, tremor, hyperglycemia, are mediated, at least partly, by sensitization of adrenergic receptors to catecholamines. Induction of adenylyl cyclase, proliferation of beta-adrenergic receptors, and a better coupling between these two has been demonstrated. Actions of thyroid hormones: growth and development, intermediary metabolism, calorigenesis, cardiovascular system, nervous system, skeletal muscle, gastrointestinal system, kidney, hemopoiesis, reproduction. And below you can see the preparations of L-tyroxine sodium: L-troxine, roxine, tyronorm, tyrox. Uses: cretinism, adult hypothyroidism, myxoedema coma, non-toxic goiter, thyroid nodule, papillary carcinoma of thyroid. Empirical uses: T4 has been used sometimes in the following conditions without any rationale. Response is unpredictable: refractory anemias, mental depression, menstrual disorders, infertility not corrected by usual treatment, chronic non-healing ulcers, obstinate constipation. Thyroid inhibitors. These are the drugs used in the case of thyrotoxicosis, excessive secretion of thyroid hormones. Classification: first are those which inhibit hormone synthesis, antithyroid drugs. Second, those which inhibit iodide trapping, ionic inhibitors. Third, those which inhibit hormone release. And fourth, those which destroy thyroid tissue. Compounds in groups 1 and 2 may be collectively called goitrogens because if given in excess, they cause enlargement of thyroid by feedback release of thyroid-stimulating hormone. The first group, inhibit hormone synthesis, antithyroid drugs. These are propylthiouracil, metimazole, and carbimazole. Antithyroid drugs bind to the thyroid peroxidase and prevent oxidation of iodotyrosyl residues, thereby inhibit iodination of tyrosine residues in thyroglobulin, and inhibit coupling of iodotyrosin residues to form T3 and T4. And below you can see the comparative characteristics of propylthiouracil and carbimazole. Uses: antithyroid drugs control thyrotoxicosis in both Graves' disease and toxic nodular goiter. Clinical improvement starts after 1 to 2 weeks or more, depending on the hormone content of the thyroid gland. Iodide-loaded patients who have received iodide-containing contrast media cough mixtures or amiodarone are less responsive. Maintenance doses are titrated on the basis of the clinical status of the patient. The second, those drugs which inhibit iodide trapping, ionic inhibitors, thiocyanates, perchlorates, and nitrates. Certain monovalent anions inhibit iodide trapping into the thyroid, probably because of similar hydrated ionic size. T4, T3 cannot be synthesized. Perchlorate is 10 times more potent than thiocyanate in blocking sodium iodide symporter, while nitrate is very weak. They are toxic and not clinically used now. Thiocyanates can cause liver, kidney, bone marrow, and brain toxicity. Perchlorates produce rashes, fever, aplastic anemia, and agranulocytosis. The third, those drugs which inhibit hormone release. Lugol solution, 5% iodine in 10% potassium iodide solution. Iodides of sodium and potassium, organic iodide. Though iodine is a constituent of thyroid hormones, it is the fastest acting thyroid inhibitor. In Graves' disease, the gland, if enlarged, shrinks, becomes firm and less vascular. The thyroid status starts returning to normal at a rate commensurate with the complete stoppage of hormone release from the gland. The thyroid gland involutes and the colloid is restored. The response to iodine and iodides is identical because elemental iodine is reduced to iodide in the intestines. With daily administration, peak effects are seen in 10 to 15 days, after which thyroid escape occurs and thyrotoxicosis may return with greater vengeance. Worsening of hyperthyroidism especially occurs in multinodular goiter. Uses: preoperative preparation, thyroid storm, prophylaxis of endemic goiter, antiseptic. Adverse effects: acute reaction, chronic overdose, iodism. And the fourth are those drugs which are destroying thyroid tissue. Radioactive iodine. Radioactive iodine is administered as the sodium salt dissolved in water and taken orally. The most common indication is hyperthyroidism due to Graves' disease or toxic nodular goiter. The average therapeutic dose is calculated on the basis of previous tracer studies and thyroid size. Higher doses are generally required for toxic multinodular goiter than for Graves' disease. The response is low, starts after 2 weeks and gradually increases, reaching the peak at 3 months or so. Thyroid status is evaluated after 3 months and a repeat dose, if needed, is given. About 20 to 40% of patients require 1 or more repeat doses. And additionally, beta-adrenergic receptors blockers. Propranolol and other non-selective beta-adrenergic receptor blockers have emerged as an important form of therapy to rapidly alleviate manifestations of thyrotoxicosis that are due to sympathetic overactivity, palpitation, tremor, nervousness, severe myopathy, sweating. They have little effect on thyroid function and the hypermetabolic state. They are used in hyperthyroidism in the following situations: while awaiting the response to propylthiouracil, carbimazole, or radioactive iodine, along with iodide for preoperative preparation before subtotal thyroidectomy, thyroid storm, thyrotoxic crisis. This is an emergency due to decompensated hyperthyroidism. And the next part of our lecture is insulin, oral hypoglycemic drugs, and glucagon. Diabetes mellitus, pancreas. It is a metabolic disorder characterized by hyperglycemia, glycosuria, hyperlipidemia, negative nitrogen balance, and sometimes ketonemia. Hormone insulin, which is hypoglycemic, synthesized in the beta cells of pancreatic islets of Langerhans in the pancreas, discovered in 1921 by Sir Frederick Grant Bunting and Dr. Charles Herbert Best. The first pure crystalline form was obtained in 1926, and the chemical structure was fully worked out in 1956. The next hormone, glucagon, hyperglycemic, was demonstrated to be present in the pancreatic islets just 2 years after the discovery of insulin in 1921. It is secreted by the alpha cells of the islets of Langerhans and is commercially produced now by recombinant DNA technology, and additionally in delta cells, somatostatin, about which we talked before. And in here you can see the schematic depiction of paracrine modulation of hormone secretion within the pancreatic islets of Langerhans. The 3 hormones released from closely situated cells influence each other's secretion and appear to provide fine-tuning of their output in response to metabolic needs: insulin, amylin, glucagon, and somatostatin. Diabetes mellitus. 2 major types of diabetes mellitus are: type 1, insulin-dependent diabetes mellitus. There is beta cell destruction in pancreatic islets. Majority of cases are autoimmune. Type 1a. Antibodies that destroy beta cells are detectable in blood, but some are idiopathic. Type 1b. No beta cell antibody is found. In all type 1 cases, circulating insulin levels are low or very low, and patients are more prone to ketosis. This type is less common and has a low degree of genetic predisposition. And type 2, non-insulin dependent diabetes mellitus. There is no loss or moderate reduction in beta cell mass. Insulin in circulation is low, normal, or even high. No anti-beta cell antibody is demonstrable. Has a high degree of genetic predisposition. Generally has a late onset, past middle age. Over 90% cases of diabetes are type 2 diabetes mellitus. Causes may be abnormality in glucoreceptor of beta cells, so that they respond at higher glucose concentration, or relative beta cell deficiency. In either way, insulin secretion is impaired, may progress to beta cell failure. Reduced sensitivity of peripheral tissues to insulin, reduction in number of insulin receptors, down-regulation of insulin receptors. Excess of hyperglycemic hormones, glucagon, etc., obesity, can cause relative insulin deficiency. The beta cells lag behind. Other rare forms of diabetes mellitus are those due to specific genetic defects, type 3, like maturity onset diabetes of young, MODY, other endocrine disorders, pancreatectomy, and gestational diabetes mellitus, GDM, type 4. Approaches to drug therapy in type 2 diabetes mellitus. You can see improve insulin availability on the left side and overcome insulin resistance on the right side. About these drugs we will talk a little later in oral hypoglycemic drugs part of the lecture. Regulation of insulin secretion. Under basal conditions, 1 unit of insulin is secreted per hour by the human pancreas. A much larger quantity is secreted after every meal. Secretion of insulin from beta cells is regulated by chemical, hormonal, and neural mechanisms. Chemical, the beta cells have a glucose sensing mechanism dependent on entry of glucose into beta cells through the aegis of a glucose transporter GLUT1 and its phosphorylation by glucokinase. Glucose entry and metabolism leads to activation of the glucose sensor, which indirectly inhibits the ATP-sensitive potassium channel, potassium ATP, resulting in partial depolarization of the beta cells. This increases intracellular calcium availability due to increased influx, decreased efflux and release from intracellular stores, exocytotic release of insulin storing granules. Other nutrients that can evoke insulin release are amino acids, fatty acids, and ketone bodies, but glucose is the principal regulator and it stimulates synthesis of insulin as well. Glucose induces a brief pulse of insulin output within 2 minutes, first phase, followed by a delayed but more sustained second phase of insulin release. The next is hormonal. A number of hormones, for example growth hormone, corticosteroids, thyroxine, modify insulin release in response to glucose. PGE has been shown to inhibit insulin release. More important are the intra-islet paracrine interactions between the hormones produced by different types of islet cells. The beta cells constitute the core of the islets and are the more abundant cell type. The alpha cells, comprising 25% of the islet cell mass, surround the core and secrete glucagon. The delta cells, from 5 to 10%, elaborating somatostatin, are interspersed between the alpha cells. There are some pancreatic polypeptide-containing cells as well. Somatostatin inhibits release of both insulin and glucagon. Glucagon evokes release of insulin as well as somatostatin. Insulin inhibits glucagon secretion. Amylin, other beta cell polypeptide released with insulin, inhibits glucagon secretion through a central site of action in the brain. The 3 hormones released from closely situated cells influence each other's secretion and appear to provide fine-tuning of their output response to metabolic needs. Figure 3 slides before. Let's come back to this figure. You can pause this slide and take a look again at this schematic depiction. And the third regulation of insulin secretion is neural. The islets are richly supplied by sympathetic and vagal nerves. Adrenergic alpha-2 receptor activation decreases insulin release, predominant, by inhibiting beta cell adenylyl cyclase. Adrenergic beta-2 stimulation increases insulin release, less prominent, by stimulating beta cell adenylyl cyclase. Cholinergic. Muscarinic activation by acetylcholine or vagal stimulation causes insulin secretion through inositol triphosphate diacylglycerol increased intracellular calcium in beta cells. These neural influences appear to govern both basal as well as evoked insulin secretion because the respective blocking agents have effects opposite to that mentioned above. The primary central site of regulation of insulin secretion is in the hypothalamus. Stimulation of ventrolateral nuclei evokes insulin release, whereas stimulation of ventromedial nuclei has the opposite effect. Actions of insulin. The overall effects of insulin are to dispose meal-derived glucose, amino acids, fatty acids, and favor storage of fuel. It is an anabolic hormone, promotes synthesis of glycogen, lipids, and protein. The actions of insulin can be summarized as facilitation of glucose transport across the cell membrane, intracellular utilization of glucose, inhibition of gluconeogenesis in the liver, inhibition of lipolysis in adipose tissue, enhancement of transcription of vascular endothelial lipoprotein lipase, and facilitation of amino acids entry and their synthesis into proteins, as well as inhibition of protein breakdown in muscle and most other cells. Types of insulin preparations. In here, first of all, you can see the types of insulins. First are rapid-acting, insulin lispro, insulin aspart, insulin glulizine. The second short-acting, regular soluble insulin. The third intermediate-acting, insulin zinc suspension or lente, neutral protamine hagedorn or isophane insulin. And long-acting, insulin glargine and insulin detamir. Their appearance, their onset peak duration in hours, and with which insulins they can be mixed. Reactions to insulin. First is hypoglycemia. The treatment is glucose, which must be given orally or IV for severe cases. The second is local reactions. The third is allergy. And fourth, edema. Some patients develop short-lived dependent edema due to sodium retention when insulin therapy is started. Drug interactions. Beta-adrenergic blockers prolong hypoglycemia by inhibiting compensatory mechanisms operating through beta-2 receptors. Beta-1 selective blockers are less liable. Warning signs of hypoglycemia like palpitation, tremor, and anxiety are masked. The rise in blood pressure can occur due to the unopposed alpha action of released adrenaline. Thiazides, furosemide, corticosteroids, oral contraceptives, salbutamol, and nifedipine tend to raise blood sugar and reduce the effectiveness of insulin. Acute ingestion of alcohol can precipitate hypoglycemia by depleting hepatic glycogen, and lithium, high-dose aspirin, and theophylline may also accentuate hypoglycemia by enhancing insulin secretion and peripheral glucose utilization. Uses of insulin. First of all, it is diabetes mellitus. Insulin is effective in all forms of diabetes mellitus and is a must for type 1 cases as well as for post-pancreatectomy diabetes and gestational diabetes. Many type 2 cases can be controlled by diet, reduction in body weight, and appropriate exercise supplemented if required by oral hypoglycemics. Insulin is needed by such patients when not controlled by diet and exercise or when these are not practicable, primary or secondary failure of oral hypoglycemics or when these drugs are not tolerated, underweight patients, temporarily to tide over infections, trauma, surgery, and pregnancy, in the perioperative period and during labor, monitored IV insulin infusion is preferable, any complication of diabetes, for example ketoacidosis, non-ketotic hyperosmolar coma, gangrene of extremities. In here you can see diagrammatic depiction of pattern of insulin action obtained with two commonly employed insulin regimens. In here you can see A, split mixed regimen, and B, basal bolus regimen. Graph A. The total daily dose of a 30 to 70 or 50 to 50 mixture of regular and neutral protamine hagedorn insulin is usually split into two split mixed regimen and injected subcutaneous before breakfast and before dinner. The advantage of Graph A is that only 2 daily injections are required, but the post-lunch glycemia may not be adequately covered and late postprandial hypoglycemia may occur. Graph B, a more intensive regimen, termed the basal bolus regimen that is now advised, needs 3-4 daily injections. Long-acting insulin, glargine, is injected once daily either before breakfast or before bedtime for basal coverage along with 2-3 mealtime injections of a rapid-acting preparation, insulin lispro or aspart. The second use of insulin is diabetic ketoacidosis, diabetic coma. Ketoacidosis of different grades generally occurs in insulin-dependent diabetics. It is infrequent in type 2 diabetes mellitus. The most common precipitating cause is infection. Others are trauma, stroke, pancreatitis, stressful conditions, and inadequate doses of insulin. The development of cardinal features of diabetic ketoacidosis is outlined in the figure on the next slide. Patients may present with varying severity. Typically, they are dehydrated, hyperventilating, and have impaired consciousness. The principles of treatment remain the same, irrespective of severity, only the vigor with which therapy is instituted is varied. Rescue therapy: insulin, intravenous fluids, potassium chloride, sodium bicarbonate, phosphate, antibiotics, and other supportive measures. And in here you can see the depiction of the development of the diabetic ketoacidosis due to insulin lack. Symptoms are shown in boxes. For example, osmotic diuresis, hypotension, shock, tachycardia, dehydration, vomiting, hyperventilation, impairment of consciousness. The third use of insulin is hyperosmolar non-ketotic hyperglycemic coma. This usually occurs in elderly type 2 patients. Its cause is obscure, but appears to be precipitated by the same factors as ketoacidosis, especially those resulting in dehydration. The general principles of treatment are the same as for ketoacidotic coma, except that faster fluid replacement is to be instituted and alkali is usually not required. Despite intensive therapy, mortality in hyperosmolar coma remains high. Treatment of precipitating factors and associated illness is vital. And few words about acute insulin resistance. This form of insulin resistance develops rapidly and is usually a short-term problem. Causes are infection, trauma, surgery, and emotional stress induce release of corticosteroids and other hyperglycemic hormones which oppose insulin action. Ketoacidosis, ketone bodies and free fatty acids inhibit glucose uptake by brain and muscle. Also, insulin binding may increase, resulting in insulin resistance. Treatment is to overcome the precipitating cause and to give high doses of regular insulin. The insulin requirement comes back to normal once the condition has been controlled. The next drugs used in diabetes mellitus are oral hypoglycemic drugs. These drugs lower blood glucose levels and are effective orally. These agents are useful in the treatment of patients who have type 2 diabetes, but who cannot be managed by diet alone. The early sulfonamides tested in the 1940s produced hypoglycemia as a side effect. Taking this lead, the first clinically acceptable sulfonylurea tolbutamide was introduced in 1957. In the 1970s, many so-called second-generation sulfonylureas were developed, which are 20 to 100 times more potent. Clinically useful biguanide fenformin was produced parallel to sulfonylureas in 1957. Newer approaches have constantly been explored and have lately yielded thiazolidinediones, meglitinide analogs, alpha-glucosidase inhibitors, and the latest are dipeptidyl peptidase 4 (DPP4) inhibitors. Classification of oral hypoglycemic drugs. First are those which are enhancing insulin secretion. They are subdivided into sulfonylureas, first-generation tolbutamide, second-generation glibenclamide, gliburide, glipizide, gliclazide, glimepiride. The second are meglitinide phenylalanine analogs, repaglinide and nataglinide. The third, glucagon-like peptide 1, GLP-1 receptor agonists, injectable drugs, exenatide and liraglutide. And fourth, dipeptidyl peptidase 4 inhibitors, sitagliptin, vildagliptin, saxagliptin, alogliptin, linagliptin. The second are those which are overcoming insulin resistance. First are biguanides, metformin, and second thiazolidinediones, pioglitazone. And third, miscellaneous antidiabetic drugs, alpha-glucosidase inhibitors, acarbose, miglitol, voglibose, amylin analog, pramlintide, dopamine D2 receptor agonist, bromocriptine, and sodium glucose cotransport 2 inhibitor, SGLT2 inhibitor, dapagliflozin. Let's discuss some of important groups in more detail. First is sulfonylureas. Actions. They increase release of insulin, decrease production of glucose in liver, increase the number of insulin receptors, effective only if have functioning beta cells. Side effect is hypoglycemia and weight gain. These drugs include these examples: glibenclamide, glipizide, and glimepiride. The next meglitinides. Actions. Nateglinide and repaglinide are non-sulfonylureas that lower blood sugar by stimulating the pancreatic secretion of insulin. In contrast to sulfonylureas, the meglitinides have a rapid onset and a short duration of action. They are categorized as postprandial glucose regulators, used as monotherapy or in combination with metformin, should be taken 10 to 30 minutes before meal. Side effects: hypoglycemia and weight gain. The third, biguanides. Actions. They increase the use of glucose by muscle and fat cells, decrease of hepatic glucose production, decrease of intestinal absorption of glucose. They doesn't cause hypoglycemia, may be used alone or in combination. Side effects include GIT disturbance and lactic acidosis. Contraindicated in liver or renal impairment, can result in lactic acidosis. This group include metformin. Thiazolidinediones. Actions. Decrease insulin resistance, regulate adipocyte production and secretion of fatty acids, as well as glucose metabolism, resulting in increased insulin sensitivity in adipose tissue, liver, and skeletal muscle. Side effects include weight gain, headache, and anemia. Contraindicated in patients with liver disease and acute myocardial infarction. May be used as monotherapy or in combination with insulin, metformin, or sulfonylurea. These drugs include pioglitazone and rosiglitazone. Alpha-glucosidase inhibitors. Actions. Inhibit alpha-glucosidase enzymes in the GI tract. Delays absorption of complex carbohydrates and simple sugars. Can be combined with sulfonylureas. Contraindicated in malabsorption, severe renal impairment. Side effects include bloating and diarrhea. This group include acarbose, miglitol, and voglibose. And in here you can see some additional and important features of oral hypoglycemics. Drugs, trade names, plasma time of half elimination, duration of action, clearance route, daily dose, number of doses per day, and possible remarks. I will pause this slide for some seconds for you to be able to check it later on. And glucagon, discovered 2 years after insulin. A hyperglycemic principle was demonstrated to be present in the pancreatic islets just 2 years after the discovery of insulin in 1921. Glucagon is a single-chain polypeptide containing 29 amino acids, molecular weight 3,500. It is secreted by the alpha cells of the islets of Langerhans and is commercially produced now by recombinant DNA technology. Regulation of secretion. Its secretion is regulated by glucose levels, other nutrients, paracrine hormones, and the nervous system. Glucose has opposite effects on insulin and glucagon release. High glucose level inhibits glucagon secretion. The incretin glucagon-like peptide 1, free fatty acids, and ketone bodies also inhibit glucagon release. Amino acids, however, induce both insulin and glucagon secretion. Insulin, amylin, and somatostatin, elaborated by the neighboring beta and delta cells, inhibit glucagon secretion. Sympathetic stimulation consistently and parasympathetic stimulation under certain conditions evokes glucagon release. Actions. Glucagon is hyperglycemic. Most of its actions are opposite to that of insulin. Glucagon causes hyperglycemia primarily by enhancing glycogenolysis and gluconeogenesis in the liver. Suppression of glucose utilization in muscle and fat contributes modestly. Its secretion is increased during fasting and is largely responsible for the high fasting blood glucose levels in type 2 diabetics. It plays an essential role in the development of diabetic ketoacidosis. Uses of glucagon. Hypoglycemia due to insulin or oral hypoglycemics. Use of glucagon is only an expedient measure for the emergency and must be followed by oral glucose sugar given repeatedly till the blood glucose level stabilizes. It may not work if hepatic glycogen is already depleted. Dose from 0.5 to 1 mg IV or IM. The next is cardiogenic shock to stimulate the heart in beta-adrenergic blocker treated patients. However, action is not very marked. And to facilitate radiographic examination of upper-lower GI tract by relaxing the stomach and intestines. Other hyperglycemics. Diazoxide, chemically related to thiazides, it inhibits insulin release from beta cells and causes hyperglycemia lasting 4 to 8 hours. Its action on ATP-sensitive potassium channels of beta cells is opposite to that of sulfonylureases. Other actions which may contribute to hyperglycemia are decreased peripheral utilization of glucose and release of catecholamines. It has been used to prevent hypoglycemia in insulinomas. Other actions are vasodilation, falling blood pressure, and antidiuresis. The next is somatostatin. It causes hyperglycemia primarily by inhibiting insulin release. And streptozocin causes selective damage to insulin-secreting beta cells. It has been used to produce experimental diabetes in animals and to treat insulin-secreting tumors of pancreas. And the last part of our lecture is examples of MCQs. A patient with diabetes mellitus experienced a loss of consciousness and convulsions after an injection of insulin. What might be the result of biochemical blood analysis for the concentration of sugar? First of all, this picture represents hypoglycemia. And in here you're supposed to know the normal levels of glucose concentration in the blood. The normal concentration of glucose in blood varies from the literature to literature, but we can say that in adults it is approximately from 4 to 6 millimole per liter, and in children from 3.3 to 5.6 millimole per liter. So in here we need to find that concentration of glucose in the blood which is least and the most possible to cause this hypoglycemia. So the correct answer will be 1.5 millimole per liter. A 56-year-old patient complaining of thirst and frequent urination was diagnosed with diabetes mellitus. Tolbutamide was prescribed. How does this drug act? So in here you need to remember or pharmacological group or mechanism of action of tolbutamide, which will be, of course, enhancement of insulin secretion. A patient in the soporous condition is delivered to the endocrinologic unit. The increasing sweating and smell of acetone from the mouth are observed. The level of glucose in the blood is 22.43 millimole per liter. The diagnosis is hyperglycemic coma. What hypoglycemic drug should be administered to the patient? So remember please that in cases in hypoglycemia we are using glucose, but in cases of hyperglycemia or especially hyperglycemic coma, which is in this case, we are using insulin with the shortest duration of action. An elderly female patient suffers from type 2 diabetes mellitus accompanied by obesity, atherosclerosis, and coronary artery disease. Basal hyperinsulinemia is also present. What treatment would be the most appropriate? So for this patient who is suffering from type 2 diabetes mellitus and with basal hyperinsulinemia, the best drug of choice will be glibenclamide. A doctor recommended iodine-containing drugs to liquidators, the victims of the Chernobyl nuclear power plant. What is the aim of this recommendation? In this situation, when there was the accident in Chernobyl nuclear power plant, there was a very high release of radioactive iodine. So the prescription of iodine-containing drugs in this case will be due to the replacement of radioactive iodine by non-radioactive iodine. Metimazole is prescribed to a patient with thyrotoxicosis. What is the mechanism of drug action? In here you need to remember the mechanism of action of metimazole, and of course it will be the decrease of the synthesis of thyroxine in the thyroid gland. Hypoglycemic drug A was prescribed to a patient with diabetes mellitus. After several weeks of treatment, the glucose level in the blood is decreased, but lactic acidosis develops in patient. Identify the group of hypoglycemic drugs for which this complication is most typical. We just talked about these drugs, and this is the specific side effect of biguanides. A hypoglycemic coma is developed in a patient owing to an overdose of insulin. Which drug should be administered for its elimination? So in here again it is hypoglycemia, and as I told you before, in cases of hypoglycemia you need to use glucose. A patient after subtotal resection of the thyroid gland receives a drug of substitutive therapy. What is the name of this drug? In cases of substitutive therapy, we need to use the hormone itself. So the drug will be thyroxine. A 45-year-old patient complains of constant thirst and marked polyuria. The glucose level in plasma is 5 millimole per liter. There is no glucose in urine. Which drug should be prescribed for the treatment of this patient? Please take a look that the glucose level in plasma is normal. There is no glucose in urine, and take a look at these options. This is the MCQ connected with diabetes insipidus, and the drug will be in here vasopressin. I wanted to add this MCQ for you not to forget that also exists diabetes insipidus, in which we are prescribing vasopressin. Thank you for the attention.